series. I'm very excited about tonight's webinar. It has nothing to do with feet, which is one of the first ones as far as EBFA webinars go, but this topic of athletic pubalgia or a sports hernia and managing pelvic imbalances in athletes is something that's very dear to heart, if I could call it that. It was an injury that I had encountered, and it is an injury that's very highly misunderstood, and it took up to 6 months for me to get the proper diagnosis. And after going from doctor to doctor, it was something extremely frustrating on how misunderstood, mistreated, and misdiagnosed I was. So it's something that I want to kind of bring to the mainstream and the attention to a lot of health and wellness and movement specialists on how we can look at this injury and similar injuries. So again, welcome to everybody. I recognize some of the faces, and it's always great seeing some new faces as well. All of the EBFA webinars are recorded and they're archived, kept on the EBFA website, ebfafitness.com. If you click under webinar, you will find all of our past webinars from 2012. So we are going to get started. My computer works. All right, so again, the importance of this topic, again, sports hernia, athletic pubalgia, or just thinking mainstream groin injuries in athletes and your everyday gym goer. So what this is lower abdominal and groin pain has prematurely ended the career of many athletes. Again, it's a very highly misunderstood area. I know orthopedic and general surgeons call the groin area or the adductor area kind of a no man's land. It's not really in the scope of an orthopedist, and it's not really falling under a general surgeon's specialty. They do a little bit more with classic hernias, and then it doesn't fall under a obstetrician or gynecologist because, again, it's a little bit of this no man's land. So athletic pubalgia, sports hernia is often misdiagnosed, improperly treated, and misunderstood. Again, I can speak about this from my firsthand experience. So if we take a detailed understanding of pelvic imbalances in athletes and in our everyday gym goer, can we prevent these injuries and then avoid lost game time, surgery, and then chronic dysfunction? So what is athletic pubalgia? This is also known as a sports hernia, osteitis pubis, where osteitis pubis is actually a symptom. That means that when you palpate the pubis bone right along where all the adductors, pectineus, gracilis insert, there's tenderness along that pubis bone. It's also known as gracilis syndrome and hockey groin syndrome. And what it is it's actually an avulsion or a tear of the rectus abdominis off of the pubis bone. Oftentimes you have an associated injury where the adductor longus can also be avulsed or torn off of the pubis bone. Depending on the severity of the athletic pubalgia, you can get a tear or a fraying of the transverse abdominals and the internal obliques. So it is a pretty traumatic injury and one that clearly looks like it would need a surgical intervention. So we are going to speak about what is the mechanism behind this injury, how can we prevent it, and then if you do have those athletes or clients who do have the surgery, which is what I had, how do you restore function back into that client or patient? So the client patient will typically present with pain on forced abdominal contraction if you have them do kind of a forced sit-up. Also along palpation along the pubis bone, you're going to have tenderness. And then if you have them do an isometric adduction of the hip, they will have tenderness along, again, the adductor longus, possibly adductor magnus as well. So if we look at the anatomy of our adductors, and we look on the bottom portion here, we see the adductor longus. Remember that athletic pubalgia has a tear of the adductor longus and the rectus abdominis. So we can totally see how fascially these two muscles are connected. They are actually direct antagonists. So the lower fibers of your rectus abdominis are actually going to posteriorly tilt your pelvis, while the adductor longus is going to pull it into an anterior tilt. So again, they're in direct opposition, which means you have to have a nice balance in motor control and strength between these two muscles. You create any imbalance between these two muscles, and that's where you get your injury. And again, it's classically the tear of the adductor longus that tears first, and then the rectus abdominis will follow. So what is the cause? Why do these athletes and clients get athletic pubalgia? What's interesting is that a common denominator when you approach an athlete or a client and they have groin pain, an anterior labral tear, snapping hip syndrome. If you've ever had a client who says when they lower their leg down, as they go into hip extension, they feel like a tendon is popping or snapping in their hip, that's very classic with pelvic imbalances. They can present with a psoas bursitis or an adductor strength. Again, common denominator between all of these injuries and these symptoms is a pelvis and pelvic floor imbalance. And what is creating this imbalance is improper motor control of what's called the pubic joint. Now, Dr. Myers in Philadelphia is one of the top surgeons and one of the founding fathers, for lack of a better word, of the surgical technique behind athletic pubalgia. And Dr. Myers really goes into what is this pubic joint. He's actually the first author to describe the pubic joint, which is kind of that anterior aspect of the pubis bone, and he considers this a joint. And what you're trying to do is create a balance between the posterior and the anterior tilters of the pelvis. So again, we have the posterior tilters, which is the lower fibers of the rectus abdominis, and you have those that pull the pubis joint into an anterior tilt, which would be our adductors. So it's maintaining the balance in that pubic joint. So, anterior pelvic anatomy, the two primary purposes of the pelvis is one, transfer weight. And then the second is to withstand the compressive forces of that weight that they are transferring. What happens when you have poor motor control within the pubic joint, it is then unable to withstand those forces. You exceed the force and then you get that tear within that muscle belly. So again, fulcrum for many of the forces is around this pubic symphysis. If you look back at the anatomy and you see all the complex anatomy of what's attaching around that pubic symphysis, it's really complex. You have the pectineus, adductor brevis, adductor longus, you have adductor magnus, you have your hamstrings, your gracilis. It's a very complex area that again is a little bit neglected, misunderstood, and is often associated with dysfunction. So trying to bring some attention to that area of the lower extremity. Okay, so pelvic stabilization. Again, in athletes, there's tremendous torque that's going around the level of that pelvis. That anterior compartment, all those adductors, psoas, rectus abdominis, unfortunately takes the brunt of these forces. The net result of all these forces is an anterior medial or anterior tilt within the pelvis. You maintain that anterior medial tilt and you start getting these overactive adductors, and that creates a myriad of problems such as TFL, underactive, gluteus medius, etc. So we want to remember that when one muscle weakens or is inhibited, these other muscles must take up those forces, and that again often leads to fatigue and injury. So if we're looking at pelvis stabilization, we want to look at what impacts negatively this pelvic stabilization. Why are these athletes or these clients or these patients unable to stabilize their pelvis? Which muscles are responsible for stabilizing the pelvis, and how can we restore stabilization back into these clients and athletes? First one is a delayed onset in transverse abdominals and the pelvic floor. So there were studies done that showed that there was a delayed activation of the transverse abdominals in athletes with long-standing groin pain. So there's clearly an association between groin pain and a delayed activation of the transverse abdominals. So before those adductors are firing, that transverse abdominal is a little bit too late, which means that it does not have a stable base to contract against. So we have to look at why are these transverse abdominals delayed? How can we improve that activation of the transverse abdominals? So again, what is the cause of this delay within the transverse abdominals? Most often it is the psoas. If your psoas, we typically think of the psoas as a muscle that's overactive, it's getting in the way, you're doing your abdominal exercises and it's firing before your abdominals can. So when most clients are doing their abs, they're really working their psoas. But what's interesting is that a lot of people actually have inhibited psoas, and it's a little bit more of the TFL that's getting in the way, the adductors, some of these other anterior pelvis or pubic joint muscles. So inhibition of the psoas can lead to further inhibition of the deep pelvic stabilizers. This means our pelvic floor, our transverse abdominals, and our internal obliques are inhibited by an inhibited psoas. So to get that proper activation of the psoas, we need our pelvic floor and our deep abdominals to fire first. So it sounds a little like a catch-22. So we need to see what is inhibiting the psoas so then we can get the deep pelvic muscles to activate so then the psoas can activate and stabilize the pelvis. So what is causing the inhibition of the psoas? There are two common causes of inhibition of the psoas as far as it relates to pelvic stabilization. First one is a facilitated or an overactive adhesion-laden quadratus lumborum. So the QL is in the lower back and it runs from the bottom of the rib cage to the top of the pelvis. In a unilateral contraction of the QL, we do a lateral flexion of the spine or of the trunk. As far as athletes are concerned, if you have an athlete who has a dominant side, such as a pitcher, a soccer player, a hockey player, you're going to see a lot of QL issues. So then those QL issues are going to lead to inhibition of the psoas. Inhibition of the psoas is going to lead to further inhibition of the deep pelvic stabilizers, including transverse abdominals, and if your QL is inhibiting your psoas. What you want to do is test the strength of your psoas. If you see that it is weak, and the way that you can test the strength of the psoas is how I do it is I have the client lie on their back with their legs bent as if they're in a chair, and then they're going to lift their leg or flex their hip greater than that 90-degree flexion, and that would activate the psoas. You want to then find a trigger point in the QL. So you're going to palpate their back and find tender areas. If you do not touch your clients as far as licensing or scope of practice, they can use a trigger point ball. Find that trigger point, lie on the ball while you're going to test the psoas. If they hold that trigger point ball on that trigger point and you then retest the psoas and you notice increased strength, then that will tell you that your facilitated QL is in fact inhibiting your psoas. So then what do? You continue releasing and breaking down all those adhesions in the QL, and then you strengthen your psoas. Second cause that can inhibit the psoas is overactive adductors. And this is, again, it's kind of like a domino effect as far as overactivation and inhibition of the psoas pulls the pelvis into this anterior medial position, which then creates overactive adductors because it's sitting in that internally rotated position. So overactive adductors can inhibit proper psoas activation, which then again further delays that pelvic stabilization activation. As it relates to athletic pubalgia and actual adductor strains, is we have scar tissue and adhesions can greatly disrupt the function of your adductors. The most common adductor that is strained or torn or injured is your adductor longus. And again, the reason that the adductor longus takes the brunt of all these forces is that it is the direct antagonist of your rectus abdominis. So if you do work with clients and you do focus on their adductors, make sure you focus a lot on that adductor longus and get in there and do some trigger point release and maintain a balance between the rest of the anterior pubic muscles. Any client who has actually had the surgery, this is a huge one because they go in and they fascially break up all of that scar tissue. If you're doing a surgical reattachment of the adductors to the pubis bone, then you have kind of this disruption of a neuromuscular control of that muscle. So very important. So how does this translate to the adductor strain and avulsion or your classic athletic pubalgia? So we have an imbalance between our adductor longus and our rectus abdominis. And we have this imbalance between the synergistic activation of our adductors and our obliques. So what are we going to do? Again, we have this imbalance between our rectus abdominis and our adductor longus. So if you have a client who has an adductor groin injury, they have athletic pubalgia, osteitis pubis, hockey groin syndrome, whatever you want to call it, you must create a balance within their rectus abdominis and their adductor longus. Remember that we need our deep pelvic floor to activate first before any of those anterior hip muscles. That means the deep pelvic stabilizers have to fire first before your psoas, before your adductor, and before your rectus abdominis. What's interesting is those who have inhibited deep pelvic muscles over-recruit their superficial muscles. So that means if your deep pelvic stabilizers are not firing, you're going to become dominant or overactive in your rectus abdominis, which again creates this antagonistic imbalance in those clients. So it's something very important to pay attention to is, are they over-recruiting their superficial abdominal muscles? Okay, second one that we want to maintain in these clients and patients is your anterior oblique fascial system, which would be the synergistic activation between your adductors and your obliques. So we can see how they're totally following the same diagonal pattern. When you have a client who has this groin pain, adductor strain, athletic pubalgia, the adductors don't really trust the obliques. So they spasm to try and stabilize because, again, they're not in a motor sync or motor firing pattern with those obliques. So we'll see when we go into the prevention and the management of these injuries, how can you slowly build trust back into those obliques so then the adductor can then create that synergistic action with the obliques. So as far as treatment with a true or a classic athletic pubalgia, these clients and patients are going to have to do surgery. This is a great example of the actual tear, and you can see how the rectus abdominis is actually torn off of the pubis bone, and it's due to the adductor longus pulling down, and fascially it then avulses the rectus abdominis with it. Some clients or some patients will have an actual adductor tear along with it, and those that are the most severe have an actual pelvic floor or transverse abdominals tear as well. So surgery, 100% need to have that done. After that surgery, and if they don't have an actual tear, the key is looking at prevention. How can we prevent these injuries and these imbalances and these symptoms in our clients and our patients? So what we need to do is focus on maintaining balance within the anterior pubic joint. Again, that's maintaining the balance between the rectus abdominis and the adductor longus. It's maintaining the stabilization of the deep pelvic muscles to fire before any of the other anterior pubic muscles. So we want to dissipate these forces of the anterior pubic joint. And what's interesting is that to properly dissipate these forces and use the anterior hip muscles, we need a little bit of an anterior tilted position, which is the athletic stance. If you're thinking of a football player or somebody who's an outfield, an athletic stance does have you in an anterior tilt with slight hip flexion. So what you need to do is integrate deep stabilization exercises in these athletes or in these clients so they can properly maintain that athletic stance without the deep abdominal shutting off and them over-recruiting the superficial muscles. So again, extremely important. That is key to it. So how do you begin to reestablish this pelvic floor activation and integration? So on the picture on the left is going all the way back. I call the athletes that I work with this, it's like going back to kindergarten. We have to go right back. You're lying on your back, and what I want you to do is an isometric activation of the transverse abdominals and the pelvic floor. So they're doing a little bit of a hollow, and then they're lifting their pelvic floor almost like a Kegel. Again, we're trying to activate and kind of get that synchronization between the deep pelvic muscles and the pelvic floor. I integrate the isometric exercises, 4 sets, 8 seconds, and then I maintain that isometric contraction and slowly lift one leg at a time. We're following this picture, just a hair off of the ground. So what they're doing is they're able to lift the leg, activating the psoas muscle while maintaining that deep pelvic floor stabilization and then releasing down. I begin to introduce that. Whenever I do the psoas activation, I have the opposite arm over the head so that we can kind of get that whole cross fiber between the adductors and the obliques on the opposite side. As the patient or the client becomes a little bit stronger, you want to really integrate that anterior oblique system. So the image on the bottom, they're doing kind of a push-pull or a puncher's cross, and you want to note that the right leg is in front and the left leg is going to cross. So it's almost as if you're getting that walking motion or that athletic stance. This picture would mimic the function of this one that a pitcher is using. The pitcher is using that anterior oblique system, so we need to have that deep stabilization, oblique action on that right side, and then the adductors on that left side firing again in a synchronized pattern. What's interesting is this system that the trainer is using on this athlete is called the Core X program, and it was actually created by a physical therapist, athletic trainer for the LA Lakers, and it's specifically designed for sports hernia, athletic pubalgia. If you do not have a patient or client who has this injury, I think this is an awesome system for anyone who has any sort of adductor imbalance, maybe an oblique deep pelvic floor delay. So you want to, again, re-emphasize that anterior oblique system, deep pelvic floor stabilization before any movement. That system, Core X, is perfect. So if we're looking at which athletes are at risk, hockey, soccer players, of course it's also known as hockey groin syndrome, so that's a common sport that you see it in. As far as hockey and soccer, theirs is a little bit more of a aggressive, you can almost see in the picture that the athlete has his leg forced adduction. That's a little bit different than a muscle imbalance. I actually saw a jiu-jitsu player 2 weeks ago, and he had similar symptoms. He had the snapping hip syndrome. Every time he was dropping his leg down into hip extension, his hip would snap, and he knew it sounded like a tendon was snapping over. What that is his psoas tendon, and if you want to learn more about it or you're not familiar with it, I would look up coxa, C-O-X-A, sultans, S-A-L-T-A-N-S. Coxa sultans is snapping hip syndrome, and again, classically associated with deep pelvic floor destabilization. So again, he was a jiu-jitsu player. They're on the ground with their hip flexed, and they lose that deep pelvic stabilization and become very much reliant on their adductors and their TFL. They start getting glute medius atrophy. Again, very classic in that sport. So if you do work with jiu-jitsu or MMA, that's a huge field that you can kind of focus and integrate these pelvic floor stabilizations and assessments for groin injury and athletic pubalgia. Last one is dancers, gymnasts, etc., ones that are using their hip flexors where they become more reliant on the movers than the deep pelvic stabilizers. So again, gymnasts is very common, and that's actually how I tore my abdominals, was doing gymnastics. Maybe that means I should not be doing gymnastics in my 30s, but that's how I got it. And again, something that I had gone from doctor to doctor. They didn't know what it was. I had torn my labrum. There's an association between groin injury and anterior labral tears. And the reason that you have that association between the groin or the adductor injury or athletic pubalgia and anterior labral tears is that destabilization of the pelvis shifts the forces into the hip joint, and the softest or the most friable part of the hip joint is the anterior labrum. So you just get this shift or this transfer of forces to the anterior aspect of that hip joint. So classically, you're going to get a lot of athletic pubalgia sports hernia with an associated labral tear. once you correct the athletic pubalgia and you surgically reattach the muscles, typically you do not have to correct the labral tear because that's not what's causing the symptoms. I had my surgery with Dr. Myers in Philadelphia and went through the whole rehab, and then I had a motor control kind of deep pelvic floor destabilization continued, and my adductors went into spasm. And again, the one thing that helped me and allowed me to kind of run again and go upstairs 4 months after surgery, still not being able to because of adductor spasm, that's clearly saying that my deep pelvic stabilizers were not active, or I could not activate them because they were inhibited. So again, I used a lot of the techniques. I did a lot of Pilates to restore that deep pelvic stabilization so that my psoas could start firing. And once my psoas started firing, my adductors could relax and I could restore proper mechanics. So if you guys have any questions specific to athletic pubalgia, groin injuries, adductor strain, please let me know. You can type them in. You can email me any questions. Again, it's a topic that's very misunderstood, misdiagnosed. If you've ever done any Google searches on it, there's a lot of conflicting data on it. And it's something that I want to bring an awareness to. How can we prevent these injuries in our athletes, clients, and patients before it becomes so severe that they actually tear one of their adductors or their abdominals? If you do want a copy of the slide, you can email me at education@ebfafitness.com. Again, education@ebfafitness.com. Send you the slide. All of our webinars are archived, and you can catch them on the website, which is ebfafitness.com. We have some great workshops that are coming up. Barefoot Training Specialists, we are in Colorado, Los Angeles, Atlanta, and then we're going to North Carolina. If you happen to be in Asia, I will see you at Asia Fit in October. And do not forget to follow us on Facebook and Twitter. So if there's any questions. Great. If you guys have any questions, again, please feel free to email me, education@ebfafitness.com. We have a great workshop or webinar that's coming up in October, and that is on vibration training and balance and stabilization. So it's exploring how we can integrate vibration training. I know a lot of you may be familiar with the power plate, how you can integrate that into your programming to improve your client and patient's balance. Have a great night.